Good afternoon, everyone. On behalf of Heart and Stroke, I'd like to welcome you all to this, our first atrial fibrillation webinar for patients and caregivers. My name is Eileen Rodriguez, and I'll be your moderator for the next hour. Before we get going and I formally introduce you to our guest speaker, I'd like to go through some housekeeping items. You were provided with two options for audio, your computer or phone. If you're using your computer, make sure to adjust the speaker's volume. You can ask questions throughout this webinar by typing them in the chat box. The speaker will finish his presentation before answering any questions. We will attempt to answer as many questions as we can in the 20 minutes we will have for Q&A. Please do not use your phone or computer mic to ask questions. If you're using a landline or telephone to listen to the webinar, please turn off your computer speakers and make sure your cell phone is not located beside your telephone. The speaker is using a webcam. You can always modify the size and location of the image on your computer screen. We are recording this session, and a link to this recording will be sent to all of you registrants after the webinar. The recording will be uploaded to Heart and Stroke's YouTube channel. Please note the speaker slides will not be available, just the recording of the webinar. With the recording, we'll send you a link to an evaluation survey. We appreciate your feedback and would encourage you to complete this short survey for us to improve your experience and to know what kind of topics might be useful to you in the future. So we have a busy agenda today, starting with a 30-minute presentation by Heart and Stroke expert, Dr. Peter Leong-Sit, and followed by a Q&A period. And now, without further ado, I'd like to introduce you to our guest speaker, Dr. Peter Leong-Sit. He's a member of the Heart Rhythm program at Western University in London, Ontario, and a heart rhythm specialist with Western University, the University Hospital. Welcome, Dr. Peter Leong-Sit.
Thank you very much. I'm just going to put this in presentation mode here. Okay, welcome everyone. Today, I've been asked to talk a little bit about atrial fibrillation, and through the registrant list, I can see that there are patients with atrial fibrillation who have signed up, as well as family members. This will be my main target audience. There are also some health caregivers, but I will be speaking at the level of patients and families who either have atrial fibrillation or are worried about how they might develop atrial fibrillation. These are my faculty disclosures in terms of the companies that I have been working with in the past. And Heart and Stroke always uses mitigation of potential bias to ensure that we are giving correct information and unbiased information. So the main objectives today, in terms of what we are aiming to do, is number one, to understand what atrial fibrillation is and what that means, to understand how your physicians will diagnose atrial fibrillation and what tests are required to do so. Number three, to understand what the main health impacts of atrial fibrillation are. So many of you who are early in the stages of atrial fibrillation will want to know what that means to your health. And finally, to understand what the key treatments are for atrial fibrillation. Since the atrial fibrillation treatments are quite varied for many patients, I'll superficially touch on the main treatment strategies, and then we can go in more detail about specific issues, perhaps during the question period. So the first task is to go over what atrial fibrillation is and what that means. In order to do that, I wanted to give some basic heart background so that you can better understand what atrial fibrillation is all about. So atrial fibrillation is the most common abnormal heart rhythm in the world. There are many different types of heart rhythm abnormalities. Some of these heart rhythm abnormalities are ones that make your heart go too slowly. Others make your heart rhythm go too fast. But there are dangerous forms of heart rhythm problems, and there are less dangerous forms of heart rhythms. Atrial fibrillation happens to be one of the most common abnormal rhythms, and so a lot of people around the world will share this diagnosis with you. In terms of how common it is, perhaps over 5% of patients over the age of 65 have atrial fibrillation, and approximately a quarter of patients above the age of 75 will eventually develop atrial fibrillation. So you can see just how common this rhythm abnormality is. It is far less common in younger patients, but we do see it in patients in as young as their teenage years as well as in their 20s and 30s. But it is a diagnosis that increases with your age. Who is at risk of getting atrial fibrillation? That was a common question asked by the registrants. There are many factors, but as an overriding factor, the main thing is stretching and aging of the heart. And so the most common reason patients will have atrial fibrillation is just simply time. So as the heart gets a little older, as it goes over the usual wear and tear of just simple aging, then you become more and more at risk of developing atrial fibrillation. And that's why we see it increase more and more as you enter your 50s, 60s, 70s, and so forth. However, there are other factors that are well known to increase the risk of atrial fibrillation. Alcohol is probably the most common social risk. That doesn't mean people should not have any alcohol, but we know that atrial fibrillation episodes are much more common, especially after a large amount of alcohol. So some patients know the term holiday heart syndrome. Atrial fibrillation has this moniker because commonly after the holidays, where you drink a little too much wine or a little too much beer, then episodes of atrial fibrillation become much more common. We do see this as well in university students and whatnot. After a weekend of drinking, they might develop atrial fibrillation even if they're in their 20s or 30s. The other main factor is things that can increase the aging of the heart because the heart is abnormal. So if you've had prior heart attacks, if you've had prior heart failure, if you have valves in your heart that are leaky, or if you have a thick heart or stretched heart, all these things can increase the chances of atrial fibrillation. Other things that put stress on the heart would include sleep apnea. This is a more and more commonly diagnosed entity for those who are big snorers at night, and you find yourself feeling unrested even after what you think was overnight sleep. You may have sleep apnea. This is a diagnosis when the snoring becomes so severe that you stop breathing overnight because of the snoring. And your partner might notice that there are times overnight where you're not breathing and then you gasp for air after many seconds. This would be a sign of sleep apnea, and you could see your family doctor to register for a sleep study because this puts you at risk of atrial fibrillation. And finally, some people call atrial fibrillation a stress rhythm, and that's because any stress to the body, whether it's an infection or an illness or after major surgery, can put you more likely into atrial fibrillation. So we still haven't gone over what atrial fibrillation is. To understand that, you have to know a little bit about the heart. The heart is a muscular pump. It has the big job of distributing blood and oxygen to the entire body, including to the brain and to all your organs. And so it's a very vital organ in the body. Like any real engine or pump, the heart has its own natural plumbing system and its own natural electrical system. So the heart is a muscle and requires the plumbing system to deliver oxygen to itself. Because it is a muscle and requires nutrients and oxygen, it has a plumbing system that delivers blood and oxygen to its own muscles. It has a completely separate electrical system, and the electrical system controls how fast the heart will beat so that it can go slowly when you're sleeping, it could speed up when you're exercising or when you're excited, and that way it could meet the demands of your body. The reason I want to bring up the plumbing system of the heart first is because many patients who I see in my clinics ask, well, if I have atrial fibrillation, I'm really worried that I'm going to get a heart attack. And this is just to point out that heart attacks are completely separate from the electrical system of the heart. A heart attack is when you have severe chest pain due to a blockage in one of the heart pipes. So this is why I'm calling it the plumbing system of the heart. When you have a blockage in the piping system of the heart, then not enough blood and oxygen goes to a part of the heart. And that part of the heart, because it's not receiving blood and oxygen, begins to die. And that's what we call a heart attack. When we're talking about atrial fibrillation, the atrial fibrillation is on the electrical side of the heart, so atrial fibrillation isn't connected directly with heart attacks. Rather, atrial fibrillation has to do with the heart's electrical system. So the heart has a normal battery pack inside the heart. It's called the sinus node, and this is the battery pack in the heart which controls the heart rate so that when you're relaxed and resting, your heart rate will be normal at 50 or 60 beats per minute. When you stand up and you're active, it might go up to 80 or 90 beats per minute. And when you're exercising, some of you can get your heart rates up to 150 beats per minute. And this is all normal control of your normal wiring system of your heart. However, some patients will develop atrial fibrillation. And this is when an abnormal part of the heart takes over control of your heart rate. It's when the top chambers of the heart begin to race. Even if you're sitting there resting, even if you're sleeping, it might begin to race, and your heart goes into this fast and irregular rhythm, which can be called atrial fibrillation. So this is a cartoon of atrial fibrillation. Here are the heart chambers in the heart where we have 4 chambers. And the reason it's called atrial fibrillation is that these 2 top chambers, which I'm pointing out with my mouse, these are the atrial chambers of the heart. And instead of pumping slowly at 60 beats per minute, they start to race at 300 or 400 beats per minute. So they're really just quivering or fibrillating. So that's why it's called atrial fibrillation. It's when these top chambers, the non-pumping chambers of the heart, begin to race very rapidly. Your actual pulse is determined by your pumping chambers. And so even if you're in atrial fibrillation, your actual heart rate might not be nearly as fast. So you could be in atrial fibrillation and have a slow pulse, or more commonly, a fast pulse. So how do we diagnose atrial fibrillation? So how does your doctor know you have atrial fibrillation? Well, first of all, we become suspicious if you develop some of the symptoms of atrial fibrillation. So a patient might come to us and tell us that they have felt that their heart is pounding or their heart races even when it's not supposed to. So they might feel that their heart is pounding or racing even when they're sleeping, even when they're lying down or sitting. Of course, when you're exercising, you expect your heart to race and you expect it to pound, so patients aren't alarmed. But when this happens out of the blue, then the patient might complain to their doctor, I'm getting heart pounding or palpitations in the chest. Other patients feel short of breath, they feel fatigued, they feel chest pain, or they feel dizziness. All these things can be from atrial fibrillation, but it's important to understand that these things can be caused by many other diagnoses as well. So just because you have these symptoms does not mean that you have atrial fibrillation, and it's up to your doctor to sort out, is your chest pain from something dangerous like a heart attack, or is it from something like atrial fibrillation? And there are many things that cause these symptoms, some of which are dangerous, many of which are not dangerous. And so you'll need your doctor's help to sort that out. So how is atrial fibrillation diagnosed? Well, clinically, it is first suspected if your doctor takes your pulse and they feel that your pulse is irregular. The normal heart will beat in a regular fashion, even though it could speed up or slow down, but your heart will beat very regularly. Atrial fibrillation is a chaotic rhythm, and so your heart rhythm will be very irregular. And so when your doctor puts his hand or her hand on your pulse and they feel it's irregular, then they might suspect atrial fibrillation. So the next test would be to get an electrical heart tracing called an ECG. An ECG is when they hook up your chest with leads. Many of you will have had this before, and it records the electrical activity in your heart. If the ECG shows atrial fibrillation, then the doctor can make that diagnosis right there and say, yes, you have atrial fibrillation and you are in it right now. However, some patients come in and out of atrial fibrillation, so they have episodes of atrial fibrillation. So the episode might last 30 seconds, it might last 10 minutes, it might last several hours. But it might be that when you're at your doctor's office, you're not feeling the symptoms that were bothering you a week ago. And so if they have a heart tracing and you're not in your episode, then your heart tracing will just show normal heart rhythm. In this case, your doctor will want to order a test where you can wear a heart monitor at home. Some of these monitors you will wear for 24 hours, others you could wear for 3 days. Some of them you can actually wear for a couple weeks. The main principle behind the heart monitor is that it has to be worn long enough that you have the symptoms during the monitor. If you have the symptoms of heart racing while you're wearing the monitor, then we could take a look at what the monitor showed and we could tell you whether or not your heart rhythm showed atrial fibrillation or something else. So this is why this test is so critical in order to make the diagnosis if your symptoms are coming and going. If you have the palpitations or heart racing and you wear the monitor, you might have many different diagnoses. And so these are 3 different examples of what we might see during heart racing symptoms. This one happens to be normal, but has heart hiccups in them that could cause very similar symptoms. The second one is actually atrial fibrillation. And the third one is a dangerous heart rhythm. And so there are many, many causes of heart racing, and we need to have a recording in order to distinguish between normal heart racing, dangerous heart racing, and atrial fibrillation. Moreover, many of these diagnoses can feel exactly the same. And so when we talk to you and ask about your symptoms, we can't tell the difference between many of these heart rhythms unless we get the recording of your heart during an episode, during the symptoms. And so that is why we try to get that heart monitor while you're having an episode, so we could distinguish between these different diagnoses. So how does atrial fibrillation affect your health? When the diagnosis of atrial fibrillation is made, your doctor likely will tell you there are two main health issues related to atrial fibrillation. The first and most important is that there is an increased risk of having a stroke. This is not a risk during the episode of atrial fibrillation. This is simply an associated risk in any patient who has had atrial fibrillation. I'll talk a little more about what a stroke is and why this is related to atrial fibrillation. The second main health issue is symptoms. So some of you will have no symptoms during atrial fibrillation, and in that case, all we care about is reducing your risk of stroke. Many others with atrial fibrillation, however, are miserable when they're having atrial fibrillation. And if the patient is feeling unwell during the atrial fibrillation, then we want to treat the atrial fibrillation as aggressively as you need us to get rid of the symptoms that some patients will have during atrial fibrillation. So let's talk about stroke first. What is a stroke? We won't go into detail about that now, but it's when part of your brain begins to die because it's not receiving oxygen and blood. And so you might have a drooping face, you might lose the ability to speak, you might have a weak arm or a weak leg suddenly out of the blue. Why is a stroke related to atrial fibrillation? Well, in this cartoon of the heart, in atrial fibrillation, you might develop clots in the heart. And that's because the heart isn't pumping as it normally does, and blood is allowed to stand still. And just like a cement truck that has stopped spinning, the cement could begin to harden. So when your heart isn't pumping normally and it's in atrial fibrillation, then clots can form inside the heart. And if the heart forms a clot, if that clot breaks off and floats to the brain, then that's how it can cause a stroke. What are the symptoms of stroke? This is a nice advertisement for patients from the Harvard Health site. It gives the moniker FAST, F-A-S-T, F for face drooping, A for arm weakness, S for speech difficulty. If you see a sudden cause of those symptoms, then it's time to call 911 because you might be having a stroke. What about issue number two? Issue number two is that, interestingly, some patients have no symptoms of atrial fibrillation. And in many ways, they are lucky because they only have to deal with the stroke risk of atrial fibrillation. However, many other patients can have one or more of all these symptoms that I discussed. And if we know that it's caused by your atrial fibrillation, then we want to treat the atrial fibrillation so that the patient can have a better quality of life. So how do I treat my atrial fibrillation? In the last 5 minutes, I'll talk about the treatments. We talk about the treatments for atrial fibrillation based on those two separate problems. So first and foremost, we want to reduce the risk of having a stroke. Your doctor will determine, based on what your other medical problems are and based on your age, whether or not you have a high enough risk of stroke to require a blood thinner. Most patients with atrial fibrillation will have a high enough risk, and therefore your doctor will recommend a blood thinner. Because I've described why atrial fibrillation leads to strokes, you understand now why a blood thinner is important. If clots form in your heart and break off and float to the brain to cause a stroke, it makes sense that we thin the blood so that clots are less likely to occur. This makes the strokes much less likely. It's an excellent treatment to reduce the risk of stroke. And in fact, the blood thinner reduces the risk of stroke almost to the level of someone who does not have atrial fibrillation. This, of course, comes with the risk of bleeding, which many patients don't want to be on a blood thinner because they're worried about bleeding, whereas we know that this is an excellent treatment because many patients, if you talk to them, will prefer a bleeding complication rather than a life-altering stroke. And so in most patients, we would highly recommend a blood thinner. In rare patients who cannot take a blood thinner safely, then we can put in an invasive device inside the heart to reduce the risks of clots forming. Some patients will know this as a Watchman device or an Amplatzer device. There are several different companies out there that make these devices. And for the rare patient who cannot be on a blood thinner, we can put in these devices into the heart to reduce the risk of stroke. This is what the heart looks like in the 4 chambers. This is the pouch called the left atrial appendage, and that is where the clots tend to form. And so if you can imagine clots forming in this little outpouching in the heart and floating to the brain, then that is what causes the stroke. The clot here is minimized if you're on a blood thinner, but if you can't be on a blood thinner, then we can plug up that pouch with either a little metal cage or a metal disc, and this is what the left atrial appendage closure is all about. And like I mentioned, there are many companies out there, but some of you will recognize this as the Watchman device or the Amplatzer plug, and so these are the 2 devices that are approved in Canada. For the second main issue, atrial fibrillation symptoms, this is the, for most patients, this is the reason why they are seeing us, because they cannot tolerate when they are in atrial fibrillation. They are either having many episodes of atrial fibrillation or they're in atrial fibrillation all the time, and they feel miserable when they're in atrial fibrillation. Some patients feel that their heart is erratic all the time. Others, when they're in atrial fibrillation, notice that they can't do as much as when they're in normal rhythm, so they get tired much easier, they get short of breath much quicker, they feel chest pain or chest discomfort. And so for those patients, your doctor will first start medications for your atrial fibrillation. There are many medications out there, and there are many different types. It's too much to go over all the different medications with you, but in general, one category of medications is to slow down your heart. So they give you medications to slow down your atrial fibrillation, and for many patients, this is all it takes, and they feel much better when their heart is slower. For other patients, this doesn't work, or the medications used to slow your heart down make you feel tired and miserable, and so you have too many side effects with the medications. Then you might be started on a second category of medications, which actually try to get rid of atrial fibrillation. Failing that, if that medication doesn't work, then there is an invasive procedure called an ablation. And this is a procedure that tries to get rid of the atrial fibrillation so that you could get off of some of these medications. An ablation is not a cure for atrial fibrillation, but in some patients, symptoms can be eliminated completely with around a 70 to 80% success rate. Here's a cartoon of the heart where we put tubes up from your leg, down from your shoulder. We go inside the heart, and this is usually under general anesthetic. It takes 3 hours or sometimes 4 hours to do our work inside the heart. And in other patients, this is not a good option because success rates are sometimes below 50%. And this all has to do with what your heart looks like, how long you've had atrial fibrillation, and whether or not you have other heart conditions. So the main take-home points as we're wrapping up here and starting with the question period is that atrial fibrillation is the most common abnormal heart rhythm in the world. It is diagnosed when you receive a heart tracing during an episode or if you wear a heart monitor. The two main health impacts is an increased risk of stroke and symptoms during atrial fibrillation. Most of you with atrial fibrillation will be started on a blood thinner to reduce the chance of having a stroke. Many of you will be started on medications to make you feel better. And some of you, if those medications fail, might need a procedure either to reduce the stroke risk or to reduce the symptom burden if the medication strategies fail. So that ends the formal presentation. I know we went through a lot there. We had to go through it relatively quickly, so there are probably many questions. Perhaps I will start with some of the questions that was asked in the registrant questionnaire. So several of you asked questions similar to the first one here. How should I exercise if I have heart problems? How should I exercise if I have atrial fibrillation? What is a safe amount of exercise for me to do? What am I allowed to do? What am I not allowed to do? So there were many variations of that question. In brief, when we are talking about atrial fibrillation is a rhythm that is not immediately life-threatening. You can live the rest of your life in atrial fibrillation. And so, in fact, there are some patients with atrial fibrillation who don't even know that they have a problem, and the atrial fibrillation is discovered accidentally. And so they go into their family doctor's office for a routine annual checkup. They feel well, they feel no problems. The doctor feels their pulse and notices it's irregular, and they get an ECG which confirms atrial fibrillation. And so while this might be a surprise to some of you, atrial fibrillation is a livable rhythm. And so there is no real restriction other than listening to your body. So what I mean by that is if you feel well while you're in atrial fibrillation, you can do all the usual things that you want to do. You can exercise, you could go for a run, but when you're feeling miserable in atrial fibrillation, then it might reduce the amount of activity that you could previously do. And so if before you were able to jog for 30 minutes, in some of you with atrial fibrillation, you might notice you get tired after 10 minutes. And so what we would ask you to do is just listen to your body. If you're feeling that you can't do what you could do before, then don't push yourself. On the other hand, if you could jog the 30 minutes exactly the same as you did before, there is no danger in doing that just because you have atrial fibrillation. So the bottom line is to listen to your body and to do what your body will allow you to do. So the second part of that is if you are feeling much more restricted now in atrial fibrillation than before, it means that your doctors need to increase your treatments for atrial fibrillation so that it is better controlled so that you can get back to the levels you were doing before the atrial fibrillation was there. So that is hopefully a reasonable answer and gives you a guide. Just to make sure some of you don't misunderstand my statements, some of you asked how much should you exercise if you've had a heart attack. This is a completely different situation and one that is specific to how bad your heart attack was, how bad the blockages in the heart pipes are. You might remember that I mentioned early on in this lecture that the heart attacks aren't related to atrial fibrillation directly. And so if you have had heart attacks, it means that you have blockages in your heart pipes, and this might make it dangerous for you to exercise. So many of you should, who have had a heart attack, should go into a cardiac rehab program where your doctors can assess how much exercise is safe for you to do, and that will depend on how bad the blockages in your heart arteries are. So that is unrelated to atrial fibrillation. The second common question I received was, when should I be worried about an episode of atrial fibrillation? When is this an emergency? And several of the family members asked, when should I worry about my family member who has atrial fibrillation? So once again, even though it sounds like a silly answer, it is a common sense situation where atrial fibrillation by itself is not an emergency. It always depends on how you are feeling. So for those of you who have atrial fibrillation and feel well, you understand this concept very easily, and that's because you can live the rest of your life in atrial fibrillation. So just because you are in atrial fibrillation doesn't mean you have to rush to the hospital. However, some of you who are very symptomatic with atrial fibrillation can't believe that you can be in atrial fibrillation for days or weeks because you just feel so unwell during an episode of atrial fibrillation. I'm not saying that you have to live that way for the rest of your life. I'm just saying that the atrial fibrillation by itself doesn't mean you have to rush to the hospital. But if you are in an episode of atrial fibrillation and you are feeling dramatically unwell, then you should seek medical attention so that they can try to get the atrial fibrillation episode under better control quickly so that you are feeling better more quickly. So let me give you a couple examples. If you develop an episode of atrial fibrillation and out of the blue, your heart starts beating erratically and irregularly, but you're feeling reasonably well, you don't have to rush to the emergency room. You can feel that your heart's abnormal. This is likely another episode of atrial fibrillation if it's been diagnosed that way in the past. And you can simply wait to see if the episode goes away on its own. You might take extra pills if that is what you were instructed to do by your doctors, but this is not an emergency. For others of you, you will develop an episode of atrial fibrillation and you will essentially be bedbound. So you have to go into bed. You can't get out of bed because you are so short of breath, or you're having so much chest pain, or you are so lightheaded that you can't do anything. While this situation may not be an emergency, this is a situation where you should go to the hospital because of how unwell you are feeling. When you are this severely symptomatic, then this deserves acute medical care attention. So it is all gauged by how severe your symptoms are. If it is something in between those two extremes, it might mean that you just need to call your family doctor and say, I am in another episode of atrial fibrillation, but I feel okay. Can I see you in the next few days so that you could check me out so that I know that what my treatment options are? And so the severity of the symptoms always gauge how bad of an emergency the situation is. There was another category of questions talking about how do I prevent atrial fibrillation. There were some patients who don't have a diagnosis of atrial fibrillation but have heard of it through family members or have heard about it through friends who have the diagnosis. And so they have asked, how do I prevent getting atrial fibrillation? It's related to another group of patients who have atrial fibrillation, but they're asking a similar question: how do I prevent second episodes or third episodes of atrial fibrillation? There are a limited number of things that you can do. The first has to do with the things that you can't control. So you can't control aging. Everyone gets older, and so in some ways you cannot prevent atrial fibrillation, in that we know that aging is probably the most important risk for atrial fibrillation. So you will never get rid of the risk of atrial fibrillation. But there are a few other things that are in your control. So for some of you, alcohol is a clear trigger for your episodes of atrial fibrillation. If this is the case, then the common sense suggestion or recommendation is to not drink alcohol. Does this mean that if you have atrial fibrillation, you are not allowed to drink any alcohol? No, it doesn't mean that, but it does ring true that the more alcohol you ingest, the more likely you might develop an episode of atrial fibrillation. The occasional glass of wine or the occasional beer should not be a major problem, but for some of you, you will notice that even after a single glass of wine, you develop atrial fibrillation. So this is very patient dependent and individualized, but we do know that reducing your alcohol intake may reduce your episodes of atrial fibrillation. Having good control of your other heart medical issues, such as high blood pressure, such as diabetes. These things can make heart problems worse and therefore atrial fibrillation more common. So making sure you go on a heart healthy diet, which means no large ingestions of salt, which will increase your blood pressure, which will increase strain on your heart, which can increase atrial fibrillation. Making sure you see your family doctor regularly so that they can control your diabetes and blood pressure medications and make sure that they're under very good control. Keeping relatively fit. So you want to have regular exercise so that we keep your heart as tuned of an engine as it can be. And these are the main things that you can do to reduce the risk of developing atrial fibrillation. If you have signs of sleep apnea, daytime sleepiness, you're a big snorer, if you have a thick neck or you're overweight, these are the risks of having sleep apnea, and making sure you get a sleep study. And if you have sleep apnea, you get treated with a sleep breathing machine. This will do you wonders to reduce the chance of developing atrial fibrillation, since sleep apnea and atrial fibrillation are very closely linked. Finally, there was a question about who is a candidate for a Watchman device or an Amplatzer device. These are the devices that can reduce your risk of stroke if you have atrial fibrillation. In Canada, these two devices have been approved. The main candidates for these devices are people who are supposed to be on a blood thinner, but aren't allowed to be on a blood thinner. So that would be the case if you, in addition to your atrial fibrillation, have had major bleeding problems in the past. You can understand the dilemma that your doctor faces is if you have to be on a blood thinner for your atrial fibrillation, but you've had life-threatening bleeding problems in the past. In this case, the blood thinner may not be safe for you to be on, and therefore they might look for alternative treatments like this Watchman device or Amplatzer device in order to reduce the risk of stroke without giving you a blood thinner, which would increase your risk of life-threatening bleeding. So that is the most common reason patients are given a device. In general, most centers across Canada are not putting in these devices simply to get patients off of a blood thinner because they don't want to be on a blood thinner. The reason why this isn't the usual case is because the blood thinners have much greater evidence in terms of being a robust reduction of stroke risk, that it is most of our preference for you to be on a blood thinner rather than a device if you can be on a blood thinner. However, the device is a very appropriate treatment if you cannot be on a blood thinner. So that, I hope, answers some of the questions that you've had. There is maybe another 10 minutes or so if more questions have come up.
Thank you for a very comprehensive presentation. We have been receiving some questions from our viewers. The first question is, can I drive with atrial fibrillation?
Excellent question. The short answer is yes. The diagnosis of atrial fibrillation has no specific impact to your driving recommendation. So the Ministry of Transport has several rules about who can drive and who cannot drive safely, and atrial fibrillation is not one of the things that is considered. However, if your atrial fibrillation is leading to severe symptoms, then some of those symptoms might disqualify you from driving. This would be exquisitely rare, but the most common symptom that might be related to atrial fibrillation would be fainting. If you are fainting, then that would be a consideration for a restricted driving license. It just so happens that fainting is not a common symptom of atrial fibrillation. But in some of you who have atrial fibrillation, fainting might be a part of the symptoms that you have, and in that case, driving restrictions may be considered. But the majority of you, atrial fibrillation and driving are usually not a problem.
Thank you. Our next question, what medication do you recommend for atrial fibrillation that does not make you feel like a zombie or want to sleep all the time?
So another great question. I touched on this briefly, but it's a good chance to talk about it in a little more detail. There are many medications out there for atrial fibrillation, and the main purpose of these medications are to control your atrial fibrillation in order to control your symptoms. So it stands to reason that if you are on a medication for your atrial fibrillation and that medication is making you feel miserable, like a zombie, then it means we should put you on something else. And that's because the whole goal is to make you feel better, not worse. I suspect that the person who asked that question is on one of the early strategies of atrial fibrillation treatment, which is to slow your heart down. That is usually the first strategy we try because it is the safest strategy, and so it makes sense to start with the simple, safe medications first. But the simple, safe first medication of slowing your heart down often makes some patients feel like they are being held back, that they feel that their body is now slow or like a zombie. And so in that case, we would move to second alternative medications. Sometimes these second alternative medications aren't prescribed commonly enough by a family doctor or by an internist or even by some cardiologists. And so they want to send these patients to a subspecialist in order to start these other types of medications. Some of these other types of medications are dangerous, and that's why not everyone is a candidate for these second-line medications. And so it requires a little more thinking on the doctor's side or a specialist in order to be on these second-line agents. But these second-line agents might get rid of the atrial fibrillation without the side effects of feeling so held back or zombie-like. Finally, if we cannot find a medication that will work, then you might be a candidate for the ablation procedure. And if the ablation is a reasonable option in you, then we might be able to get you off the medication that is making you feel like a zombie. And so those are the general things that I would say. I didn't go over specific medications because some of them might be dangerous for a particular person. So I don't want to go over medications and have you go to your doctor and say, I want to be on this medication because it might be dangerous for you. And so without going through specific medications, there are half a dozen medications out there that may or may not be right for you. And if you're feeling unwell with the specific one you're on, then it means we should be trying something else so that we can make you feel better.
We have one question. Are there any home blood pressure machines which can tell you if you are in AFib, or do they just register an irregular rhythm but non-specific?
To be honest, I am not intimately familiar with all the blood pressure machines out there, so I don't know how good they can be. But they're even on a basic blood pressure machine that you have at home, there could be some signs that you are in atrial fibrillation. So on the most basic machine, it will give you 3 number readings. It will give you your top blood pressure number, which is called the systolic blood pressure. It will give you your low blood pressure number. That's called the diastolic blood pressure. And it will often give you a third number, which is your heart rate. So one of the signs that you might have atrial fibrillation is if your heart rate is unusually high. If you are sitting there quietly at home, resting and doing nothing, and you are taking your own blood pressure and you haven't just been exercising, then a normal person's resting heart rate is typically between 50 and 90 or 100, usually on the lower end of that. So most of you will have a resting heart rate of 50 to 80 beats per minute. So if you are sitting there resting and you take your blood pressure and your heart rate happens to be 120, then one of the causes of that might be atrial fibrillation. There are some machines out there that might identify that your heart rhythm is irregular, and that might be atrial fibrillation, but I am not so aware of what those blood pressure machines can do, so I don't want to guess what those things are. So I can't answer that question completely.
Thank you. We have time for one more question. What's the difference between atrial flutter and atrial fibrillation?
Very good question. This is these are 2 different heart rhythms in the heart. Sometimes I call them best friend rhythms because when you have atrial fibrillation, you also have a high chance of having atrial flutter and vice versa. If you've been told you have atrial flutter, you have a very high chance of developing atrial fibrillation in the future. And so that's why I call them best friends, because when you see one, the other one is not too far behind. From symptom standpoint, a patient cannot tell the difference between the two things very easily. And in most cases, they feel exactly the same. They also have very similar implications. So everything I've talked about today is also true for atrial flutter. It has the same associated risk of stroke. It has the same risk of symptom problems. It has similar drugs that treat atrial flutter. It has similar ablation procedures for atrial flutter. So the only real issue distinguishing the two is for your doctor. When your doctor looks at your heart tracing, atrial flutter looks different than atrial fibrillation. And there is one meaningful implication, and that is that atrial flutter is much more easily cured by an ablation procedure when compared to atrial fibrillation. And so if you have atrial flutter, then we would offer the ablation procedure much earlier than we would for atrial fibrillation, because it has a much higher curative success rate, and it's a shorter procedure, an easier procedure. And so that is the key difference between atrial flutter and atrial fibrillation. But for most of you, you could treat these two things very similarly. And in fact, some doctors will call this atrial fibrillation / flutter because it's a very similar entity that goes hand in hand.
Thank you.
You're welcome.
So unfortunately, we don't have more time for more questions, but I want to close this webinar with a final note. We'd like to let you know that you're not alone in this. If you have experienced heart disease or stroke, or are caring for someone who is, connecting with other people who know what you're going through can help. So we have 2 Facebook groups, one for survivors and one for those who care for them. All you need to do is go to our Facebook page and join any of those groups. We also have some resources on our website and the Canadian Cardiovascular Society. In the next couple of days, you will receive an email, follow-up email with the evaluation questionnaire and with the link to this recording. If you have any questions in the future, you can send it to Heart and Stroke Health Presents at heartandstroke.ca. Finally, I'd like to thank Dr. Leong-Sit for sharing your expertise with us today. And to all of you, wherever home or work is, thank you for donating your time at lunchtime. Thanks again and goodbye.